You're welcome. Thank you. Good morning, directors, assistant directors, chief physiotherapists, and all the students, and every other person. All protocol observed. Good morning to you all. I am Nurse Onya from UNTH, Respiratory Department. I'm here today. I'm happy. I'm glad to be in your midst to discuss a vital and important topic in pulmonary function tests. And one of them is spirometry. Please give me a slide. After our discussion today, we'll be able to know what spirometry is all about, which is very vital in physiotherapy practice. Next slide, please. We are going to start with introduction. And from introduction, we are going to define spirometry. Please, can you bold the date? Spirometry is the gold standard for diagnosis of spirometry of respiratory diseases. This is the most common of the pulmonary please, can you, or do I let me use this place? I'm not seeing this very. Can I use my own system? Yes, I'm with my own system. Okay. It's not bright then, no. Let me use it. Sorry. Okay. Hope it's not recorded. Yeah? Okay, it's recorded. Just a second to see. Okay. C'est facile. I will use my laptop. Okay. Okay, sorry for the delay. So from my introduction, We are now starting with definition. Spirometry is the gold standard for diagnosis of respiratory diseases. And this is the most common of the pulmonary function tests. It measures lung function, specifically the amount and speed of air widely used in diagnosis and monitoring lung diseases like asthma, chronic obstructive diseases, in brackets COPD, and pulmonary fibrosis. Spirometry also helps in the early detection of respiratory condition, which is crucial for timely management and treatment. Overview of respiratory physiology. We are going to talk about mechanism of respiration in a man takes place in two phases. And those two phases are, number one, inspiration, expiration. Then we are going to explain what inspiration is all. I know I can understand that all of us knows the mechanism of respiration. But for the interest of our topic today and our lecture, we are going to touch them one by one. Then inspiration, this is the process of inhaling air into the lungs. During inspiration, the muscle of the diaphragm contracts and the thoracic cavity we feel the lungs during inspiration when you take in air. Then during expiration, this is the process of exhaling air from the lung during expiration, and the muscle of the diaphragm relaxes. Sorry, this is the process of exhaling air from the lungs. During expiration, the muscle of the diaphragm relaxes. Air is exhaled from the lungs. Then, how does spirometry measure lung function and detect abnormalities in the process? By measuring how much air you exhale and how much you exhale. Spirometry can evaluate a broad range of lung diseases. Then we have indication for spirometry. Why do we carry out spirometry in respiratory clinic or respiratory diseases? Diagnostic purpose, like in asthma. Spirometry helps confirm the diagnosis by measuring airflow limitations, often improved by bronchodilators. Then, secondly, chronic obstructive pulmonary diseases, COPD. Spirometry identifies airflow obstruction, crucial for diagnosing COPD. Then other respiratory conditions. Spirometry can be used to detect interstitial lung disease, restrictive lung disease, and early sign of pulmonary pulmonary issues in smokers. Signs of pulmonary issues in smokers. Then monitoring disease progression. is used to monitor the effectiveness of treatment for chronic conditions like asthma and COPD. Respiratory test tracks changes in lung function, helping adjust treatment over time. Operative assessment. Before major surgeries, spirometry can help to assess the lung function to predict is necessary. We have spirometry done to assess the lung of the patient, the lung fumes, and then chemicals, like people working in factory workers and miners. Spirometry can detect lung damage or occasional disease such as silicosis or asbestosis. Spirometry is not just for diagnosis, but also for monitoring and preventing complications. It plays a crucial role or critical role in both clinical setting and then clinical setting and occupational health. Then we are going into spirometry parameters. There are some parameters we need to know when we are doing spirometry or when we are carrying out spirometry. One of them is forced vital capacity, which is LVC. Then we define LVC as the total volume of air we exhale during a forced breath after taking a deep inspiration. The total volume of air exhaled during a forced breath after taking a deep breath. Then clinical relevance. LVC can indicate restrictive ventilatory disease. Disease-specific cage compliance has been kyphoscoliosis or after thoracolplasty. That is the operation done in the surgery done in the chest. Thoracolplasty. Decreased lung compliance as in pulmonary fibrosis. Disease volume of lungs as in empyema. That is when there is a pulse in the pleural cavity. Pneumothorax, obesity, and pulmonary edema or respiratory muscle weakness as in certain central nervous system disease, such as poliomyelitis. Then, secondly, forced expiratory volume in 1 second, FEV1. Then, definition: the volume of that can be forcibly exhaled in the first second. That air you take in forcibly in 1 second, that is called FEV1. Clinical relevance. One of the most important parameters for diagnosis of obstructive lung disease, like asthma, chronic obstructive disease, chronic bronchitis, etc., where air exhalation is slower and more difficult. Where exhalation is lower and more difficult, that's when we detect complication or abnormality with FEV1 when you do spirometry. So it's a very important tool when you are diagnosing patients with bronchitis, empyema, and asthma. Then FEV1 stroke LVC ratio, calculation of that is definition of FEV1 stroke FVC ratio. The ratio of FEV1 to FVC expressed as percentage. Then clinical reference in using this low ratio of less than 10% indicates obstructive lung disease, where airway is now narrow, especially in COPD, chronic obstructive diseases, or asthma. Normal or high ratio with reduced FVC suggests restrictive lung disease. You know, in FEV1, we say we notice that is when there's obstruction. When the FEV1 is low, that's when you know that we have obstruction. But in restriction, we have we notice that in FEV1, that is the percentage percentage between the FEV1 and FVC. Then you know it's restrictive lung disease. Then peak expiratory flow, PEF. Definition: the maximum speed of exhalation achieved during the test. Then clinical reference. PEF help assess airflow limitation as is used for monitoring patients with asthma at home. You can use the PEF, it's not like a spirometry, that one, PEF, peak expiratory flow. You can take it home and use it and monitor patients with asthma in your home. Then forced expiratory flow, which is FEF, 25 to 75%. Measures the air flow in the middle portion of exhalation, often used for early detection of small airway diseases. FEF, use it to, like in bronchos. That's when we notice the in smaller airways, like in bronchos. We use EFE. If to notice patients with smaller airway diseases. That one measures the airflow in the middle portion of exhalation. Then maximum mid expiratory flow. Measure the air flow in the middle. Maximum mid expiratory flow. Measure the air as taken from the fluid volume curve and measured in flow, MEF. This one is the peak expiratory flow as taken from the fluid volume curve and measured in liters per second. It should theoretically be identical to peak expiratory flow. So MEF and the FEF, both of them work hand in hand. They measure the same thing, which is, however, by meter and giving liter per minute. Have graph. Next slide, please. So that we can see the graph showing a typical spirometry curve, volume time curve, and the flow volume loop. We can see from the diagram there that we have expiration, we have liters, which is the lung capacity, the volume of the air that enters the lung. Then we have the volume liter, we have flow, we have FEV1, all of them shown in the graph. The next slide. Identifying criteria for establishing a respiratory and obstructive defect. In spirometry, obstructive and respiratory defects are identified based on specific pattern of lung function parameters, primarily focused on the FEV1 and FVC and ratio FEV1 / FVC ratio and FVC, which is forced vital capacity. Then one, obstructive lung disease. In obstructive lung disease, we define it as an obstruction in the lung, the airways, when the airways are narrowed, causing resistance to airflow, especially during exhalation, When there's an obstruction, when you take it, they can take in air. But to bring out air will be difficult in patients with obstruction. Just like in asthma, when you take in air, they are taking air, spirometry, you find out that they cannot bring out the air they take in. There will be residual air in the lungs. Then criteria for obstructive defects, FEV1 stroke LVC ratio, which is less than 70% or below the lower limit of normal, LLN, which may vary with age. Then FEV1 reduced. Then the lower the FEV1, the more severe the obstruction. When you notice that after spirometry, you notice that FEV1 is reduced, then you know that there's a severe obstruction in that patient. So FEV may be normal or reduced, especially in severe obstruction due to air trapping. As I earlier said, that during spirometry, obstruction in a patient that has an obstruction, when the air is taken in, you will see that the patient, to blow out the whole air in the lung will be difficult. So there will be trapping in the lung. So you notice that LVC may be normal or reduced, but the FEV1 is low, less than 70%. FEV1, and the ratio is less than 70%. FEV1 is very, very low. So in patients with obstructive lung disease. Then key conditions, like in asthma, as we earlier said, chronic obstructive pulmonary disease, and bronchiectasis. Severity grading for obstruction based on FEV1, then percentage predicted. Mild FEV is greater than 80%, greater or equal to 80% predicted. Moderate FEV1, 50 to 79% predicted. Then severe FEV1, 30 to 49% predicted. Then severe, very severe FEV1 is less than 30% predicted. Then in restrictive lung disease, we define that one as a restrictive lung disease, as the lung expansion is limited. In restrictive lung disease, you see that expansion of the lung is limited, leading to reduced volume, lung volume. So the patient cannot take in, when the patient take in enough, when the patient take in air, patient cannot take in air, cannot even breathe because the lungs are restricted. Then we can see from the curve showing the normal obstructive and restrictive lung spirometry. Then you see the volume curve, you see the time curve. Then you can see that the curve is not, the PEF mildly reduced. You can see the contour shape of the curve. Okay, pointer. Okay. You can see the curve. This one is mildly reduced. The curve, this one is in normal lung spirometry. PEF, we have the peak, have the flow. The expiration go down smoothly to the volume curve. Then the inspiration, which is normal. But when you can see the time graph flow very, very smoothly and ended very, very well with the LVC. But when you come to the obstruction, you can see the concave, how it curves, showing that there's an obstruction. The patient cannot bring out the air, which he exhales into the lung. Then in restriction, you can see that there is peak. The PEF is normal and is mildly reduced, but there's an obstruction there because it is restricted. The curve is not well-rounded, the inspiration and the expiration. So we go into factors affecting lung volume and capacity. Lung volume and capacity can be identified by various physiological, environmental, and pathological factors. Underlying these factors is crucial when interpreting spirometry results and diagnosing lung conditions. One is age. Lung volume and capacity generally peak in early adults and decline in age. The lung volume and the lung capacity of a younger person is not the same in an older person. And when you are carrying out the spirometry, you find out that younger ones can do it, freely. They can do it more than the adult patients. Like the day I tried the spirometry, I was like, so this is what these kids do. It's very difficult for me. But when you see the kids blowing out the air in their lungs, it looks very easy, but it's not easy in the older adults. So age affects it. So it's one of the factors that affect lung volume and capacity in spirometry. Gender. On average, male tends to have larger lung volume compared to female due to difference in body size, and thoracic dimensions. So, larger total lung function, TLC, and vital capacity, VC, which is the vital capacity. In female, is smaller, but when adjusted for height, the difference is maximized. Then height plays a very important role. Individuals tend to have larger lung volume and capacity due to larger thoracic cavities and greater lung surface area. Tall individuals increase total lung capacity, TLC, and vital capacity in tall people. Shorter people have lower their lung capacity, total lung capacity, and vital capacity. Ranges for body, ranges within normal, ranges for body size, smaller lung volume, but still within normal range. What this place is telling us that the taller the person, the more the total lung capacity and vital capacity. But when you are like me, when you are short, your lung capacity and your vital capacity will be low. But it does not necessarily mean that it's not normal. It's normal. Then body composition. Body mass index, BMI, and fat distribution can influence lung volume. Obesity reduces lung volume, especially respiratory reserve volume, and functional residual capacity, FRC, due to excess weight on the chest and diaphragm, limiting the expansion. Nobody even slightly higher lung volume relative to body mass. So when you are fat, it will affect your total lung capacity and FDC. Physical activities. When you exercise, you find out that lung efficiency and capacity is improved. Athletes, people that do exercise, they have their lung capacity and their total lung capacity is improved. And the person that is not that is sedimentary, that does not do exercise, you find out that the person has improved their lung capacity and vital capacity. Then in altitude, so that climb, those people that do exercise, like hiking or live in a high-rising house, climbing staircase every day, you see that the total lung capacity of that person will be more and better than the person that is not doing exercise at all. That's why we should advise our patients, even children and adults, to do exercise because of your total lung capacity and your vital capacity. The people that smoke, smoking frequently reduces lung volume, it reduces and capacity, primarily by damaging the lung tissue and airways. The smoker, anybody that is smoking is damaging the lung, it will reduce the total lung capacity and the vital capacity. Smokers decrease false vital capacity and increase residual volume. When the reduces residual volume, when the smoker breathes out air during spirometry, there will be residual air, just like in asthma, because of the obstruction there. Then question, spirometry. Pressure affected. Lung volume can vary based on body position. When you stand, maximum volume, especially vital capacity, due to better diaphragm movement and lung expansion. When you are standing, you are standing upright. then your lung capacity, total lung capacity, and vital capacity is maintained and good. But when you are lying down, it presses on the spine, on the diaphragm, so that it reduces lung volume, particularly functional residual volume and the respiratory reserve volume, as the abdominal content press against the diaphragm. Or when you are sitting like this during spirometry, so when you are doing so, you tell your patient to stand upright so that air can flow in and flow out easily. Then in pregnancy, as pregnancy progresses, the growth thrust restricts the diaphragm ability to move downwards, reducing the lung volume. Especially in third trimester, it reduces functional residual capacity and the respiratory reserve volume. The tidal volume often increases to meet increased oxygen demand. Then disease states can affect like certain diseases like asthma, COPD, and they affect total lung capacity. They affect VC, and because there is an obstruction, so this affects it. Then environmental factor like air quality and exposure to pollutants can impact lung function. Then pollution and allergy, chronic exposure to lead, to inflammation and narrowing of the airway, reducing capacity over time. When you expose yourself to food, expose yourself to smoke and pollutants, chemicals, at the time you start having a lung issue, your lung will be obstructed. It will be difficult. So when you see food, see smoke, whatever, or dust, or they are all triggers, you know, to lung pollutants. They are not good for the lung at all. So you keep away from them. Then genetics also affect it. Genetic predisposition can influence lung size and function. Inheritable conditions like cystic fibrosis or alpha-1 antitrypsin deficiency can affect lung growth, development, and elasticity, reducing the lung capacity. So any disease condition you inherit from your parents due to genetics, like cystic fibrosis, can affect lung capacity. Then lung compliance and elasticity. That one, lung compliance, ability to expand, and elasticity, ability to return to original size, influences lung volume. High compliance, easier lung expansion. Example, in empyema, leading to increased lung volume, but with poor recoil. It cannot recoil back in empyema. When you blow out air, then to recoil back, the elasticity is too much, but it cannot recoil back. Then air resistance also affects it. Increased airway resistance, especially in asthma, reduce airflow and affect lung volume, like forced expiratory volume, FEV1, narrow air, lower forced expiratory volume and capacity due to difficulty moving air out of the lung. We have said it earlier that in asthma is very difficult. When you take in air, to bring it out is a problem. Understanding this factor is essential when evaluating lung function tests, as they help to contextualize normal or abnormal spirometry results based on individual unique characteristics and the environment. So we go over to spirometry procedure. Performing spirometry requires precise steps to ensure accurate, reliable results. The procedure involves patient preparation and the use of spirometer and proper technique during the best blow. Is a step-by-step guide on how to perform spirometry. When you want to perform spirometry, there are steps that will guide you. First of all, prepare your patient, explain the procedure to the patient, obtain consent for the patient. I'm about to do spirometry for you. Are you accepting it? If it's a baby, you ask the mother. Then obtain medical history. Ask the patient if they have taken any bronchodilator or medication within the first 24 hours. Some medications may need to be withheld before the test, as they can affect the results. Yes, if you have asthma, or bronchitis, and you take your inhaler, when you do spirometry, it will not give you a better result. So 24 hours before the test, you tell the patient not to take bronchodilators. Maybe when after the test, if you want to do post-spirometry, you can now give a bronchodilator to assess to know the type of asthma or the type of respiratory lung disease that the patient has. That one helps. Then you obtain, you position the patient very, very well. Ensure the patient is sitting upright and standing for the test. Or stand, you can sit, you can stand, and the back should be straight with feet flat on the ground. Patient should take a good posture while taking spirometry. Instruct the patient to keep their chin slightly elevated and avoid airway obstruction. If that will obstruct the airway during spirometry, you tell the patient you undo tight clothing, you remove any tight clothing that could restrict close chest movement, coughing, deep breathing, and other actions that could alter lung function immediately before the test. Even smoking, heavy meal, and vigorous exercises for at least 1 hour before the test. You tell the patient to rest before the test. When they come, tell the patient, like children that move around, sometimes I take them to the spirometry room, sit down here and rest. Because they will not understand. After some time, I will now conduct the test. It's very, very necessary. Speaking of the spirometry, when you are doing the spirometry, you sit up the spirometry so that you can get a good, you don't bend it, sit it up. Then instruct the patient on the technique, what you're about to do for the patient. The patient should you direct the patient on what to do. The spirometry, the mouthpiece, that patient, you should guide the patient. Take enough air into the lung, then you blow out. Then with motivation, and you help the patient. Then after that one, you tell the patient to use after explaining to the patient the procedure, use your nose clip. A nose clip may be used to prevent air from escaping through the nose during the test. This ensures that all air is exhaled through the mouth. So you don't just leave this. Sometimes we use hand to close the nose. Sometimes you can tell the patient to hold the breath. The patient can hold the breath because in children, we are in children clinic. So if you tell them to put the air in the tube on their nose, some of them will be so afraid. So what you do is that you tell the person, hold your breath. The baby will hold the breath. Then you now tell the patient to blow. The patient to blow the air into the spirometry machine, making sure that the lips is tightly closed with the mouthpiece. Then perform the pulse vital capacity. Blow out hard and fast. It's fast. It's a fast test. It's not like you just blow air. You blow it with fast. It's a fast, it's with speed. In fact, you call it speed. It's for the patient to exhale forcefully and quickly as possible. Of their lungs into the mouthpiece. This is the most crucial or important part of the test, because patient must, empty the lungs. The more air you take into the lungs, you make sure the patient take enough air. Make sure that patient exhale all the air. If not, it will not give you a good result. Then complete exhalation. The exhalation should be continued to at least 6 seconds or until the spirometer indicates that the test is complete. Ensure that the patient does not stop too soon, as incomplete exhalation will lead to inaccurate results. Inaccurate results. So you make sure that the patient continues. Don't allow the patient to stop breathing out air. You encourage the patient, keep on blowing. Bring out all the air. Then when the patient did not bring out the air, but you know the patient has taken enough air, then as a technologist, scientist, physiotherapist, a doctor, when you see the results, you can now assess the type of obstruction, whether the patient has obstruction or restrictive lung disease. Then you perform at least 3 acceptable trials. The test should be repeated at least 3 times to ensure consistency and accuracy. And the best 2 results should be within 150 millionth of each other, both for ED1 and FDC. If the results vary more than this, repeat the test until acceptable and reproducible trials are obtained. It must be reproducible. The test must be acceptable. When it's not, when the three of them are not in line, when you are carrying out the test, you look at the curve. Not three of them must be acceptable and it must be reproducible, having the same pattern. If not, you have not done good spirometry. Okay, thank you. Then you assess the quality of the results. Check for quality criteria, acceptable criteria, good start. The patient must have started exhaling quickly and forcefully to avoid hesitation. There should be no hesitation when you are doing spirometry. Then no coughing during the first second of exhalation. There should be no coughing, which should affect FEV1. When patient is coughing, you stop the spirometry because it will affect the FEV1. You might give a wrong data to the doctor, which is not good. Complete exhalation, ensure the patient or wrong diagnosis, ensure the patient did not stop too early, and that exhalation continues until the lung were emptied at 6 seconds. So the lung must be emptied. If it's not emptied, make sure from the practice, when you are carrying out the spirometry, you look out the techniques. You must know the techniques so that you make sure that patient you do what you're supposed to do. As a technician, as a scientist, as a physiotherapist, you do what you're supposed to do, what you're supposed to do. So a patient will not. Some of them, you see them maneuvering things. Let's have one class, please. You see them, they will be shifting when they are doing spirometry. So you make sure that your eyes is on the patient so that you get a good result. Then post-test procedure. You clean the spirometer after using. All the equipment should be carbolized, remove and discard disposable mouthpiece, follow the spirometer cleaning disinfection protocol, and prevent cross-examination or contamination, cross-contamination, infection from one patient to another. Inform the patient, let the patient know that the test is complete, and inform them about any follow-up test and procedures if necessary. Then provide results for the patient. Then optimal bronchodilator if indicated. Then if you want to do post spirometry, it depends on what you want. If you want to do post spirometry, it depends on what the doctor wants, what your therapist wants. If you want to do post, then you can now administer your bronchodilator inhaler to the patient. Then you now repeat tell the patient to wait for 15 minutes. Then you now repeat your spirometry. Then perform spirometry again, following the same step to evaluate any change in lung function. Post-bronchodilator is significant improvement in FEV1 or FVC, which is less than 12% or is less than 200 mils, indicates reversibility, often seen in asthma. When you after the bronchodilator, when you give it, the response, if the FVC is less than 12% during your calculation, or your FVC is less than 200 mils, it indicates that it's reversing. Then you now know that is an asthma patient. Then key spirometry measurement, FVC, forced vital capacity, total amount of air, exhale forcefully after taking a deep breath, FEV, which I have mentioned before. Closure. When the FMA organs is closed, you can see from the thinking, when the epiglottis is closed, you can see patient can do like this, patient can stop, even try to stop swallowing air, or swallowing speed while the spirometry is being carried out. So all these things is what you'll be looking at so that you get a very good result. It's a very practical thing. It's the practice. There's practice we use in spirometry. So all those things is what you observe when you are now doing patient spirometry, so that there will be no artifact. That's what we call artifacts. All those errors in spirometry. Closing of the tongue inside the mouthpiece, closure of the epiglottis and other. Then no valsalva maneuver or obstruction. Patients should not use the valsalva maneuver, closing the airway and pushing during the exhalation. And there should be no obstruction and blockage of the airway. So then we frequently stop blowing, and the machine will be reading it. So you tell the patient and say you are not doing the right thing, so that you can get for our own good to get a good result. And there should be no leak. Some of them, we tell them to put their lips around the mouthpiece. Some of them will just put it like this, as in like this. They will not put it inside. The lips should be sealed around the mouthpiece. So all those things is what you should, wash out, so that you get an acceptable result. There is reproducibility criteria. Repeated and consistent result. The spirometric test should be performed at least 3 times, and the result must be consistent and ensure accuracy. FEV1 and FVC value from the best 2 efforts should be within 150 mils for each other. If the difference between the 2 best value exceed 150, additional attempts should be made. If exceed 150, you should try again. The 3 maneuvers, some machine, you continue. Some patients will do up to 5, depending on the type of machine. So then we exceed to 5, 10 maneuvers, but the must be reproducible. The criteria should be acceptable and reproducible. So if the volume is more than 150, additional attempts should be made. If the patient is unable to achieve reproducibility after second attempt, the test may be considered suboptimal. So you should continue until you get the best result from the patient. Thank you. Sometimes you see that you do all those things. At the end of the day, the patient will not be eager. You have to encourage the patient and assist the patient to make a good spirometry so that good result will be achieved. Satisfactory effort, maximal effort. The patient should exhale with maximal effort throughout the maneuver. Adequate effort can be led to underestimation of FEV1, FVC, which is a wrong, what is wrong? Which will give us a wrong diagnosis. No early termination of the test. The patient should not stop. You should blow out longer. If you don't blow out longer, if you don't blow out longer, it will affect the LVC. The patient does not blow out longer. It will affect the LVC, the forced vital capacity, which will give a wrong result. Then adequate spread between maneuver. Patient must allow to rest between each maneuver. After each test, you tell the patient to rest. Then it's not another one. Patient should rest till, usually about 30 seconds to 1 minute between attempts to prevent fatigue, because it's not easy to do spirometry. Fatigue can affect the ability to perform repeatable maneuver and lead to inconsistent results. When the patient is tired, you can see the patient is tired. And some of them will come in, when they have long diseases, it's not easy to blow out air. So fatigue can even affect it more. So when you are doing spirometry, you allow the patient to rest 30 seconds or 1 minute in between each maneuver. Then appropriate use of equipment, calibration of spirometer. That one is another topic on its own. Calibration, you calibrate your machine. Some of them calibrate every year. Some machine, you calibrate every 6 months, depending on the type of spirometer you are using. So you calibrate your machine. If you don't calibrate it, it will not give you a good result. Even our weighing scale, we calibrate in this spirometry. We are all separate. It's not like every other equipment that every other person is using. We have our own because we maintain them. We calibrate body machine, weighing scale, everything. Sometimes you be measuring this thing, the height. You check them often to see if there's an alteration, because all these things affect spirometry result. Then ensure a clean, disposable mouthpiece is used for each patient to prevent contamination. You cannot come to the hospital and when you carry another disease to your house, you carbolize them everywhere, make them clean so that nosocomial infection, patient will not go home with nosocomial infection. Then spirometry interpretation. Interpreting spirometry involves evaluating various parameters to assess lung function and diagnose potential respiratory conditions. The most critical value in spirometry interpretation are forced vital capacity. Forced vital capacity, which is the FVC, forced expiratory volume in 1 second, FEV, and the FEV1/FVC, the percentage, the ratio. Then the key steps in spirometry interpretation: assess FEV1 and FVC ratio. The ratio is the percentage of the total lung capacity that a person can exhale, that is taken in the first second of a forced breath. Normal range is greater than 70%, or the lower limit of normal, LLM, based on the age, gender, and height. Low ratio indicates obstructive lung disease, especially asthma. We have repeated this thing before, but it's good we keep on so that it can sink into our brain. Normal or high ratio requires further analysis to rule out obstructive. Then evaluate FVC, is total amount of air a person can exhale after a full inhalation. Low FVC, which is less than 80%, suggests restrictive lung disease or severe obstruction with air trapping in the lung. Normal FVC rules out restriction, but does not rule out obstruction. But you do a spirometry for a patient, and you can see that the curve is normal and everything. You should look at the parameters, look at them, so that you can see the percentage. Everybody value. Machine will give you the predictive value because of the age, the height, the race, Because all these things what you key into the computer, when you key it into the system, then the machine will be recording all of them. That is the good thing about spirometer. So of the patient, you see all those parameters that you'll be looking into, not only the curve. So you look at the parameters, look at the curve, the length, the time curve, the volume curve, and every other thing. So you should be very, very observant when you are doing your spirometry. Then evaluate LVC. LVC is the total amount of air a person can exhale after a full exhalation. Then you evaluate FEV1. FEV1 measures how much air a person can forcibly exhale into the lung in the first second. Low FEV indicates obstruction and restriction depending on the FEV1 and FVC ratio. Normal FEV1 generally suggests normal lung function, unless other parameters are abnormal, which I've just mentioned. You should not see things on the face value. You must critically observe the result. Not determine obstruction or restriction pattern. Then we have mentioned them before. Then restrictive defects, FEV1, FVC ratio is normal. In restrictive, can you see that FEV1 and FVC is normal in restrictive lung disease? Then there is reduced FVC, which is less than 80%. Then FEV1 is reduced. Example, pulmonary fibrosis, then another neuromuscular diseases is needed to confirm restriction. Then assess the severity of the defect. The severity of the obstruction and the restrictive defect can be guided using the FEV1 percentage predicted. Mild FEV1, which is greater than 80%, moderate predicted, severe is 30 to 49. Then FEV1, which is less than 30, is predicted to be very severe. Then we have you can see our typical lung curve there, which shows the abnormal and normal in the breeze. The obstructive and restrictive, the stenosis, when the lung is scarred, you can see the curve, typical flow lung curve. Like in this one is obstruction, restriction. This one is in stenosis. When the curve, the curve will not be normal, as we have shown before. All these things what we have shown before, and other lung diseases, empyema, bronchitis, bronchiectasis, all of them, they are shown here. It can never be normal. We see the shape of the loop and the lung volume is never the same. Then the contraindication. There are absolute contraindications. Recent myocardial infarction or unstable angina, recent thoracic, abdominal or eye surgery, and pneumothorax, hemoptysis of energy, uncontrolled hypertension, aneurysm, cerebral or thoracic or abdominal. All these things, when you have myocardial infarction, you don't do spirometry in a patient. When you have pneumothorax, you don't do it. And we have relative contraindications. Like in recent, somebody have a stroke recently, you don't conduct a spirometry on that patient. Acute respiratory infection, like in flu, pneumonia, and cold, you don't do spirometry. Then on cooperative patient or inability to follow instructions, which I say some of them will come, they will not follow instructions, you don't force them. If you cannot encourage them, cannot convince the patient, leave the patient. Then chest or abdominal pains, example, in rib fracture. When the rib is fractured, you don't do spirometry, or else you collapse the lung. Then nausea or vomiting, you don't do. or patient that has just eaten and is filled, the tummy is filled up. You don't do yours. You ask all those questions before you do past and medical history. When we started earlier, so when you want to do spirometry, you take past and present medical history. What did you eat this morning? When did you eat? Because if you are doing the spirometry, patients will vomit the whole food on you when you are, conducting the spirometry. It's a vital spirometry conclusion. Spirometry is a vital, non-invasive test used to assess lung function, diagnosis conditions like asthma, and monitor treatment progress by measuring key parameters like FVC, FEV1. It helps identify obstructive and respiratory lung diseases when conducted correctly. Spirometry is a reliable result that guides clinical decision making. If you don't do a correct spirometry, it will not make good decision in your clinical place. Then, why generally safe? The test has contradictions or contraindications and requires patient preparation and technique for accuracy. Overall, is a valuable tool, offering clear insights into pulmonary health. Thank you. I should give you. Okay. Please, can we give her another round of applause? We want to thank our presenter for a detailed presentation. I wouldn't want to waste our time trying to summarize because she's also going to run a clinic now. So, just briefly, spirometry is very important to us as physiotherapists because whatever we do, we try to increase lung volume. So if a patient has obstructive disease, it begins to affect lung volumes. And when lung volume is affected, when I was introducing her, it affects capacity and functional ability. So we are going to take only 2 questions. I'm going to take 2 questions from us and 2 questions for some people, for our audience online. But every other question, we can still deal with it in the group. And this workshop, we're going to upload it on our YouTube channel. We will drop the link and you follow the link and ask your questions and get more details. So if we have more questions after now, you can drop the question or you can send it to me. I'll post it to the group. We will continue getting answers from her. So I don't know if anybody has question here. Any question or contribution or comments? Anything from the students, interns? Okay.
Thank you for your presentation. I think you should have given us the predicted values for FEV1 and the FVC. You have given us maybe for this height, the predicted value is this. Maybe a table to guide us. Thank you.
Thank you for the question you asked. If you would have listened, then you said that you can, recall that I said that predicted value is being given by the spirometer, the machine. I said that is a very good thing about that machine. It gives you the predicted value when your weight, your height, your ethnicity or race, then all your parameters. When you just see into the system, the machine does give you the predicted value. Then in terms of predicted value, we now look your results because of your height, your weight, your whatever, all your parameters. Then the machine will give us what you're supposed to blow out. What you blow out is not what I will blow out. First, you have a bigger lung capacity. You are taller than me, which I mentioned in the age. Besides, I use myself as an example that I'm short. Taller person like me. So I cannot use your predicted value as my own. You have your own because of your size, your weight, your age,
with this. So that's it. Once I get into the system, the machine will give your critical value. From there, you access other parameters. So that's just it.
Okay, thank you. Any other question?
Please, my if changing weather cause obstructive disorder. And then in your calibration, let's understand that it's calibration of very good question. Thank you for the question. Then I said that calibration, when I was giving my lecture, it's a topic on its own. And the management of the spirometer machine and every other is another topic on its own. Then in weather, because in lab management, this question you are asking now will come in, which is another topic. If I start them today, we will not leave them. Which I told my chief. I told her that it's a very broad topic, which you cannot download here now. You cannot download it now. So it's for another day. Then the weather can affect it because we have barometer, which we keep into in our lab. That barometer will give you the weather temperature. We give you the weather temperature, and if the weather is too cold, you recalibrate the machine. Once you want to operate the machine will recalibrate. That is, we use 3 mils depending on the type of system you are using, type of spirometer you are using. So the computer will even tell you the weather is the barometer we use to measure the weather temperature. You will see it will read them. All those things is what you feed into the computer before you start conducting spirometer. So it's a very good question. But we should be for another day. We teach ourselves how to calibrate it so that you get a good result when you are managing your patients. So it's another day. Weather affects spirometry. That is the lack of calibration affects the machine. It will not give you a good result. Lack of not taking patient proper data will give you wrong rating. So very, very sensitive, I can say.
Okay.
You have to be patient when you are doing spirometry. Of all those you have to follow the line. Thank you.
Okay, thank you very much.
You're welcome.
We have one question from Ajuzie Ginikachukwu. Please, can you unmute yourself and ask your question? Ginika, can you ask your question?
For patients that are completing. Because of one completing patient, like I remember Brenda told us that it was a case. So what of maybe they done? There any other thing you can use for them? Like for patients that are not completing and check the pulmonary function, pulmonary function test. That is one. There are other things. So I try to see cystic fibrosis clinic and prostate clinic. People have your present there. I don't know. Since we came back there from South Africa, there in the clinic, have you seen any patients like that? Because there, because you know, it's a convection, there are so many of them over there. I don't know. Have you come across that case? Because I remember there were some patients in the ward. We're thinking that they were querying fibrosis. So we're thinking that eventually become that. At the end of the day, they diagnose fibrosis insufficiency. So cystic fibrosis, they usually have this problem of failure to thrive.
Yes.
And fibrosis insufficiency also has that problem of
Yes.
so eventually they diagnose that. I've never seen it. Also my practice today. That's a cystic fibrosis. During your course of your listening, you have ever come across such person or go against this because we don't see for patient elderly. But I know maybe a little percentage is for Africa. I don't know. Have you come across that case?
Okay. Thank you for your question, my director. The first question you asked, you said the uncooperative patient that is not cooperative. You know, we are in children department, children clinic. We have seen a lot of them. But you have a way of, bringing them closer to you because they are kids. We don't shake them away. Sometimes we use even little things to lure them in. You smile, you tell them good things about the hospital. That we are their friends. They should come close. We can give them gifts. Sometimes we give balloons. Sometimes we give biscuits. Sometimes we give mineral. I bought mineral for most. I promise you I will give you, and that promise I will keep to it. So you see that most of them, when you get closer, because they thought you give them injection as a nurse, or you harm them because they are in the hospital. But we normally tell them in our, where I was trained, you see Anne, my supervisor, the way she handles those kids. She will tell you that whenever you enter this door, know that you are shut down with no more injection. Our environment is free of injection and other drip and whatever and drug. And you can see the machine we are using there is different from what we are using here because their own is more sophisticated. They use like a cartoon network to, I don't know how they do it, incorporate it into the computer. So they can blow and you see them playing games in the computer. So once you bring the child in, but you don't have it here, then I still believe God that in due time, our government will provide it for us. So by the special grace of God, once you bring them in and show them that games, they will be interested in the treatment. And you tell them, you blow. When they are uncooperative, you should demonstrate it to them. You bring your own mouthpiece, put it and blow. You can be dancing and with them, doing like a baby. You blow, 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 and the person will smile. Before you know it, you draw the uncooperative child very close to you. So that you learn the tactics you use. And at the end of the day, none of them reject my offer here. There are some of them I call young. I use a lot of things to be able to draw them closer. Even drawing their blood when we are doing our research. You see them, what I will use tactics, bring them closer, and you see that what they refuse to do initially, they will start doing them because they are kids. Then secondly, I was involved in that in the care of that patient. I don't know if I answered the first question. Then the patient I was involved in the treatment of was system. That I was called to come and for the baby that was there. We did it. But we thought it was cystic fibrosis. That's why even as a physiotherapy, this spirometry is very, very good. But when you want to collect, because if you do this, through the course of spirometry, when you suffer, when the patient is suffering, you can see that they produce just like a classic fibrosis and other chest infection. You see that they will produce protein, and you give the person specimen for it, and you collect and go to the lab and analyze it and know whether the patient needs that or not. So I said, all of them. I went there. I did this cooking for me. Maybe at the end of the day, when I was called by Tima. We did it. And those investigations helped them to arrive at the conclusion. That and emphasis and keep the place in this in our clinic. But the city fibrosis is not common. It's not very common. But we have not done research. Maybe we conduct, all of us will conduct research about that. That is the next step to that. Myself, every one of us, maybe we conduct research. Why is it not, or are we not diagnosing wrong diagnosis? So you understand. So it's left all of us to come together as a team and we do our research on that issue. Then let's know if it's wrong diagnosis or we don't have it. I'm ready anytime you research.
Okay, we'll take the last question. And I believe you've already started answering the question. Ginika wants to know, what is the place of physiotherapy in the use of spirometry? That is when we are asked to see patients with chest. So what's the place of physiotherapy?
A lot of people have a lot of things. You have a lot of things. Because if you do when you see a patient with when you are assessing your patient, you take your medical history. So you find out that patient has lung collapse. You do your chest to the patient. You cannot do your patient to the patient. If you find out that this patient is not fit to do your physiotherapy exercise on the patient or the lungs, you leave the patient because the knowledge of spirometry will help you. When you did the spirometry and you find out you find out that this is restrictive, this is obstructive, and this is lung restrictive and obstructive, you now rule out the patient and know how you tackle that patient, how you handle that. It matters. The exercise you give to the patient, so you need it even more than every other person. You need it. The doctors will see that to be able to prescribe drug, but you directly handle the lungs. You directly handle the lungs. It's not them. You must find them. So you need the knowledge of it. It will help you. You can read the result of the spirometry. You know when your patient needs it or not. And you are supposed to have machine here and be doing it. Every patient that comes to you, including your spirometry. If you don't, you cannot, there's one you use, smaller one. The people can afford that. You use the smaller, you cannot go for that because we are still developing country. You can't go for that machine as you can afford. So you get smaller one, you treat your patient, you print out the result, you look at the parameter. You know what you can handle or what you can do with the patient. But sometimes you damage into it, and you might damage the lung the more. That is why you damage the lung.
Okay, thank you for your contribution. Just like you have said, I believe spirometry is very important for physiotherapy because spirometry results guide practice. If a patient has obstructive pulmonary disease, what you will do for that patient is not what you will do when it is restrictive. Because when there is obstruction, they could have early closure of airway. So the chest physio you institute it on a patient with obstructive disease will be different. If it is restrictive, you know that this patient is battling with lung volume. That means there is high lung recoil. So when you look at mechanisms of breathing and the laws that their roles in allowing patients to breathe in, that is what spirometry will now help you to see. So it guides practice. When we are doing open heart, we struggled so much to see if we can get bedside spirometer. Because one of the post-op complications of open heart surgery patient is lung collapse. So it is very important that when you are treating and rehabilitating, you can also tell them to do spirometry so that you see if what you are doing is making any sense. And they can also come down with a lot of secretion and all that. So it's very important, and that is why we're looking at it today. Thank you very much. Is there any other question in line? So on behalf of the department, I really want to appreciate you for coming. We're very glad. And it's beautiful that at the end of your presentation, you have now proposed research, which is important. So we will accept your hand of relationship with regards to that. So thank you so much for coming. Ma? Okay, please, those online that are interested, please reach out to us if you're interested in any research. It will not be bad if we do a kind of national survey, multi-centers research. We appreciate our colleagues that are online. We appreciate your participation and the questions you have asked. We thank you so much. And we hope to see you again. So let's give her a round of applause. Thank you. Okay, we have come to the end of today's presentation. Thank you.